Welcome back, everyone. I hope you enjoyed your breakout sessions. And here we are in our sixth session today of the virtual Tribal ALTSA HCS AAA Fall Summit. And our next presentation is going to be on health homes with Nicole Dronin from Quality Assurance at ALTSA. And she will be sharing with us, giving some information on the implementation process, the cost of setting up a program, decisions to be made regarding leading or care coordination organization contracts. So with that, I'll turn it over to you, Nicole.
Perfect. Thank you very much. So hi, everybody. Thank you so much for having both Nicole Bishop and I, Nicole Dronin, to present the Health Home Program today at the summit. We're going to be talking a little bit about the Health Home Program. First of all, we will talk just a little bit about what the Health Home Program is, and then how you could, as a tribal entity, become a lead or a care coordination organization, which we also call a CCO. So, okay, next slide. Perfect. So again, the objectives are just the overview, the requirements to become a health home lead, and then the requirements to become a health home CCO. Again, care coordination organization. I'll probably say CCO quite a bit, so just try to keep that in mind, or hopefully I'll remember to actually say care coordination organization. Okay, next slide. Oh, we can just skip that one. Perfect. So what is the Health Home? So the Health Home program is designed to be person-centered, focusing on improving the health by providing tools and supports to empower clients and their families. As a result, clients have a better understanding of how to address their healthcare needs, which in turn helps to avoid avoidable healthcare costs. The care coordinators who actually provide the service, they are not only medically based, it reaches across all service systems, including specialty care, behavioral health, long-term services and supports. And this is accomplished through better care coordination between the client and all of their providers to encourage involvement and independence. The Health Home program is designed to ensure clients receive the right care at the right time with the right provider. It also really works through care transitions, that are better coordinated, as this is a situation where bad outcomes could have a negative impact on clients, such as rehospitalizations, which also increase costs. So the care coordinators, again, the ones that provide the service, they provide a way to bridge the systems of care. This helps to decrease duplication of services and also identifies potential gaps in care that, if addressed early, can keep the clients healthier for longer stretches of time. Okay, next screen. Thank you. So this just is kind of a good visual and example of the integration path. Prior to the care coordinator involvement with the Health Home program, the client was responsible to do all the work. They were feeling like they were on their own. They were confused about which program pays for which item or service. They didn't know who to call for what. And they spent too much time and energy trying to navigate, as we all know, a complex system of care. So the Health Home, in the Health Home program, the role of the Health Home coordinator is partnering with all beneficiaries, their families, providers, and any other agency involved with the client to ensure that care is coordinated across systems. Clients who receive care explain that one service is not more important than the other, and the achievement to better outcomes means that the system must recognize that the needs of the client are interrelated. So next slide. And this is just the Health Home model. So the program is jointly managed by DSHS and HCA, but it is based in the communities and delivered at the local level. So the state, kind of how this diagram works, is the state, HCA and DSHS contract with lead entities. So these agencies or entities could be managed care organizations, AAAs, community-based organizations, who then contract with multiple care coordination organizations to deliver the service. So so it's kind of the trickle down effect. So the AAAs or the CBOs are well positioned in the community for this role of serving as care coordinating and coordinating the care. And the care coordination organizations in turn hire qualified care coordinators who provide face-to-face care coordination and other services such as referrals to community resources, hospital discharge coordination, transportation, interpreter services, housing, and Medicaid eligibility, and that's just to name a few. The intent is for the service to actively engage the client in behavior change and to assist them in fully integrating at the community level. And this requires fidelity to evidence-based practice models. The care coordinations may include federally qualified health centers, HIV/AIDS organizations, the Area Agency on Aging, pediatric clinics, and other community-based medical and social support organizations and tribal entities also. The care coordinators are qualified. They have specific required education and licensing requirements. They are employed by the organizations to provide the health home service. The services can be provided through face-to-face contact, telephonic, and electronic contact delivered and overseen by persons with specific credentials. This has changed just a little bit, obviously due to the new COVID area on how services are being provided. And it's really based on which each lead still being able to stay within the contract requirements and getting a little creative down to the care coordination organization. So it differs by each lead and care coordination organization. So the credentials for to be a health home care coordinator include nurses, social workers, mental health counselors, chemical dependency professionals, and that's just to name a few also. Okay, next slide. All right, so to be eligible, the clients must be on Medicaid or be dual eligible. They have to have a PRISM risk score of 1.5 or greater, and that's a predictive risk modeling that gives you that 1.5 or greater. They have to have a chronic condition and be at risk for a second, and this also includes all ages. So some clients are unable to enroll in the program. Let's see here. Some clients are unable to enroll in the program, even if they do meet criteria. This is due to restrictions on how the health home program is administered. And it's administered like one of the biggest things is that it cannot duplicate services. So if the clients are enrolled in care management programs through the program for all-inclusive care for the elderly, they are not to be enrolled into the health home program. Also, if they're on a primary care case management enrollment, that also prohibits participation in the program because it's saying that it would be potentially a duplication of services. A client can always opt out of the primary care case management at any time, but that's something that could be discussed on what that would look like and how that would be moving forward. Also, clients with comparable health insurance plans, to addition to Medicaid, are not enrolled or cannot be enrolled into a health home program. So just an example of this would be Medicare Part C, TRICARE, or commercial insurance as an example. Okay, next slide. Thank you. So the basics, the health home services, and we always want to make sure that we know not to be confused with the home health services. That's a different set. I'm not sure why when CMS came out, they wanted to call it health home because home health was already there, but they did. So they are truly a new set of Medicaid benefits payable to the care coordination organizations providing services. So participation in the program is voluntary. It is no cost to the clients. Again, as I said, it doesn't duplicate services or change any of the current providers or benefits. It is a community-based intensive care coordination that's across the existing delivery system. So, we want them to be in the community where they are. So, the client knows the resources in their community. They visit Okay, I'm sorry. So the care coordinator knows the resources in the community and they visit clients' home or at the location of client's choice. So, and And then again, not to be confused with home health. This is a unique aspect of the Health Home program, and it really ties home life to the client's healthcare. Okay, next slide. So these are just the core health homes, the 6 core health home services: comprehensive care management, care coordination, health promotion, comprehensive transitional care, individual and family support, and then referrals to community and social support services. Okay, just one moment here. Okay, and next slide. Thank you. All right, so sorry, just one moment here. Okay, so the enrollment process. Eligible enrollees that do not have the American Indian Alaska Native indicator are automatically enrolled into the Health Home program, and they're assigned to a lead to do outreach, and then the lead would assign them to a CCO and to do the outreach and engagement. So the American Indian Alaska Native clients must give their consent to be enrolled. And that would occur prior to the enrollment to the lead. So the client would give their consent to be enrolled, and then the healthcare authority would enroll them based on where they would like to be enrolled. So, and then when contracting as a care coordination organizations, tribes can specify what clients they want to serve. So they could potentially serve all eligible clients, dual eligible coverage, only the American Indian Alaska Native population. It would be up to them, and that would be a conversation that would be had. And then the next slide, thank you. And then reimbursement. So if a service is completed face-to-face, the care coordination organization would receive the Indian Health Service rate. If the encounter was not done face-to-face, the care coordination organization would receive the tier rates, which are below on the slide. And it's important to note that these tiered rates are listed for fee-for-service leads, not the managed care organization leads, because we do have both. The managed care organization leads may have a lower rate. Okay, next slide. Thank you. Okay, so this is just talking about the client health outcomes due to the program. We've documented several key health outcomes for participants in the Health Home program, including increased patient activation, so they're engaged in their own care and in their self-management of their chronic health conditions, decreased inpatient admissions, decreased nursing facility admissions, and increased use of home and community-based long-term services and supports. People report that they're better able to manage their own health and see improved life experience. And yeah, so this is really important to see that the data is showing that the health outcomes are way higher due to the care coordinator and engaging the clients in their own care. And so I believe I'm going to keep going. Yes, okay. All right, so okay, so the lead requirements. So if you were considering becoming a lead or a care coordination organization, these are the 2 separate requirements. So I'm going to first talk about what it would be to be a lead entity, and then what it would be in the requirements just to become a care coordination organization. Next slide. Thank you. So there's 3 ways to become involved in the Health Home program. So these are the different paths. You could contract with the state, with HCA, the Healthcare Authority, to be a lead entity. You could also contract with a lead entity to be a care coordination organization, or a CCO, or you can partner with a current lead or care coordination organization to work with your tribal members. And then I'll address the requirements to become a lead entity or a CCO if you're interested in partnering with a lead. And if you're interested in partnering with a lead or what that would look like, you can always email myself, Nicole Bishop, who's the contract manager at the Healthcare Authority, or Antal, and we can help start to facilitate those conversations. Okay, next slide. Okay, so lead requirements. There we go. So lead organizations are responsible for administrative functions, data collection, and reporting and payment of their contracted care coordination organizations. In order to support their network and reporting requirements, they will need the following. So they will need a platform where the care coordinators can document all of the visit notes and the health action plan. And the health action plan is really what surrounds the client. There are short and long-term goals, and so that you have to document the health home or the health action plan. And so you would need a platform to do that. You need to have the ability to translate the HIPAA transactions, which may require a contract with a practice management company. And then there are several HIPAA transactions that will need to be translated, including an eligibility file, but also to submit encounters for payment through Provider One. And there are several vendor contracts that leads are responsible for procuring. This is Insignia, and Insignia scores several assessments that are required for the HAP. Collective medical technologies or other notification system alerts that alerts your client to that your client has been in the hospital or in the emergency department. And then One Health Port is where the leads submit the health action plans. So the lead would need an agreement signed with One Health Port, also have the ability to create the files in a format required to import. So these are kind of, it seems like a lot. If you know, after the presentation or after the summit is over and you're thinking about this, we definitely can have more conversations between Nicole, Ann, and I on what this actually looks like. Okay, next slide. Okay. All right, and so again, let's see. So lead requirements, again, as a lead, you're also required to contract with the care coordination organizations that actually provide the health home services, and they will will include reviewing all of the care coordination organization files and fulfilling training requirements for the care coordinator. So the lead responsibilities regarding training include having a trainer train. Okay, so you have to have a trainer, and so what they need to do is they need to take a 2-day care coordination training, and then you also would need to facilitate those trainings for the care coordinators 2 or 3 times a year, and then also participate in bi-monthly training meetings. Brendy Byzantiner, who is the health home trainer at ALTSA, she is the one that coordinates all of this. And then they would have other administrative lead functions too, including developing policies and procedures, reporting information to the state, and then the payment to the CCOs. Okay, next slide. Okay, and then you can just move to the next slide. Thank you. So what it would require to become a CCO. So if you're more interested in a path to becoming a care coordination organization, what the steps you would take is you would need a contract with an existing lead. If interested, we can always provide you with a list of the leads in your area. And since enrollment is different as a care coordination organization, you would provide a list of potential and interested people to the lead. Then they would work with the healthcare authority to determine eligibility, and then set them up with your agency to do outreach and enrollment. Enrollment can be completed in a few days, so it's really not that cumbersome. You, as a care coordination organization, you would be responsible for hiring the care coordinators to provide the health home services to your clients. And again, if you become a CCO and you want to, you work with the lead entity, they will really kind of walk you through exactly what this would look like and how to get the steps done. And then we, as the state, the healthcare authority and DSHS are always here to help support and provide technical assistance and troubleshoot anything. So there are going to be other requirements that are required by the lead, that they would have those conversations with you that would help them carry out their lead functions. That does include billing, reporting, billing, monitoring staff, and participation in lead network meetings. Okay, next slide. Okay, so here is just some of our contact information. My information is at the top, and then Nicole Bishop is the Health Home Contract Manager. And then again, you can always contact Andal too. She's superstar for the tribal entities, so absolutely contact her. And then the next slide just shows some resources. You can email the Health Home inbox, which is the healthhome@hca.wa.gov, and both of the websites for DSHS and the Healthcare Authority have a pretty extensive information, and so you can always look at that and then contact us with other questions. All right, and then the next slide. So just some closing thoughts. We just wanted to circle back to the beauty of the Health Home program. Not only does the program provide a bridge between the client and all of their systems of care, but it also focuses on social determinants of health in a person-centered way that has produced so many amazing outcomes for the health system as a whole and more profoundly at the personal level. So, and the last slide, I believe, is just questions. I went through that pretty quickly, but if there are questions, I'm gladly to answer anything that I can.
Yes, there are a number of questions in the section, so let me go through them. Unless somebody else wanted to, but I'll be happy to do it. First question, how does Medicare Advantage plans interact with health homes?
So if you have a Medicare Advantage plan, they are considering that as being a duplication of services for health home. Is that actually true? I don't know. And so it's about having probably a conversation with the client on what the benefits are to the health home to the Medicare Advantage plans. Because as of now, if you have a Medicare Advantage plan, you are not eligible for the health home program.
Wonderful. Next question then. How does COVID impact tribes' ability to receive tribal rate, with most organizations not conducting face-to-face visits at this time? Thank you.
Yeah, okay. Was Nicole able to join even as an attendee? Do we know?
She didn't. No, she couldn't join. She couldn't join.
Okay. Okay. I just want to make sure. So I don't believe at this point it's affecting the tribal rate. I can ask for clarification. Nicole Bishop, who was not able to get on the call, she's really more versed on that end. But we have been doing some workarounds due to COVID, and so I don't believe that it would actually affect the tribal rate at the moment, just because even though I said face-to-face or non-face-to-face, I believe that there could potentially be a workaround for that right now. But I can clarify with Nicole or Anne just to double check that what I'm saying is correct.
Wonderful. And do you recommend tribes connecting with or contracting with multiple leads? I'm sorry.
No, that's okay. Well, it would be, what we state in general is that it would actually be beneficial to contract with multiple leads. The tribes could be a little different in just depending on what you're going to be willing to provide, who the services are going to be willing to provide to. So we always kind of say start out with one or two, but you also have to remember that most lead entities are going to have different platforms. So if you want to contract with multiple leads, you just have to remember that your care coordinators could potentially be documenting in multiple different systems. And so to start, I would say, getting your feet wet a little bit, but then, we do have multiple care coordination organizations that do contract with multiple leads. You just kind of have to remember the pros and the cons, but they're more likely would get you, the caseload that you need as a care coordination organization.
Hi, Nicole. A couple more questions we had come up here. Do you know how many tribal entities are currently participating in the Health Home program?
I believe right now there is 2.
Okay.
I believe, again, Nicole knows a lot more about this. I do believe we have Macaw, and I believe that there is another contract coming through. The lead entity right now for that is the Olympic, it's O3A, so the Olympic Area Agency on Aging, that is doing the contract work. And so, but I believe that there's 2.
Okay, great. And then we just had a comment here that Health Homes is an amazing program.
It really is.
So we don't have any more questions that have come in yet. You might have already answered this, but if an organization wants to become a lead, then it sounds like you will provide technical assistance to really help them achieve that status. Is that correct?
Yes. Yeah. So there is a couple, I mean, there's quite a few steps to becoming a lead, but we definitely can help walk through that. All the leads throughout the state are really great at supporting each other and helping kind of provide all that technical assistance all around, but we definitely are here too, yes.
Okay, and another question just came in. What recommendations do you have for tribes in choosing a lead to contract with? What quality in a lead should a tribe look for? It's a great question.
Yeah, that is a very great question. Could you repeat the first part of that again for me? I apologize.
Sure. What recommendations do you have for tribes in choosing a lead to contract with? Okay. What should they be thinking about and looking for in a lead?
So looking for in a lead, I would say, now I just got all tripped up. I'm sorry. So the lead, so the qualities for a lead would be somebody that could manage multiple programs. Multiple like care coordination organizations. We do have ones that kind of partner with each other to be able to get along. I don't know why I'm totally tripping up. I apologize, everybody. But the leads would be able to ones that would be able to hold the platforms and be able to do all of the contract work. We do contract monitoring every year. So being able to do those quality assurance with the care coordination organizations, one that would be really involved. So I think that the program is about building relationships between the clients and the care coordinators. It would be the same for lead and a CCO partnership.
Great, thank you. And you did have a list there of the lead requirements. So making sure the tribes become familiar with that. And so they have that in mind when they're seeking those partnerships, that lead can meet those requirements.
Right, yes, absolutely.
Right.
Thank you.
Another comment came in that the North Central ACH facilitated a health home care coordinator fishbowl activity yesterday. The recording of the session will be available soon and may be a useful tool for those with questions specific to the role of the care coordinator.
Right. Yeah, that's excellent. And there is a network map out that has just become live. They used some of the data on that fishbowl conversation yesterday in the North Sound to be able to show where the care coordination organizations are, where the lead entities are. It also shows some gaps on where service coverage is. So that would be something that you could potentially look at. I can get the web link to that. I believe it's on the HCA webpage, but we can always get that link too. And then, if you do want to become a lead, or the difference between a lead CCO, you could look at all the contract requirements that we could get to you, or again, they're on the Healthcare Authority website too. Look at policies and procedures and see if they do fall in line with what you would need as a lead or a CCO.
Okay, great. Yeah, and another comment just came in that they would love to see the recording of the fishbowl conversation. So it sounds like that would provide a lot of helpful information.
Yeah.
Great. So I'm just waiting to see if a couple more comments come in before we wrap up. That was a lot of information to take in, Nicole.
It was a lot of information in a short amount of time. So Nicole and I did a presentation on the health homes last year at the summit also. We did that more as just a general, what is the health home program? And so this time we really wanted to dive deep as, we do have it is 2 tribes that have contracted, and then we have 2 in the works right now. And so we just want to know what that actually looks like so we can go ahead as, and provide the health home program, which is so amazing and really does help with social determinants of health and health outcomes, that we want to serve all vulnerable populations. And, we really want specifically for, in this context, to be able to help the tribal members be in this program to live a longer, successful life and being able to take care of their own health.
Mm-hmm. Great.
So, yep.
And with that, I think we'll wrap up this session. And thank you so much again, Nicole, for the great information.
Sure. Thank you.
So I think we